Good. Okay. Good morning. My name is Dr. Stephen Little. I'm the program director for the core cardiovascular training at Houston Methodist. I will, in just a moment, be introducing the two ground round speakers for this morning. But first, a few announcements. We're live broadcasting via live stream and via YouTube. So when you have questions at the end, please do use the microphone. It's much easier for the recording. Consider subscribing to our YouTube channel and get these notifications about all these videos. For the viewers, if you'd like to submit a question, you just text the word DeBakey, and then the code you use is 37607, and then you can interact with us from the remote location. You can also submit questions via a live stream feed, and that is find the video on livestream.com/HMH-edu. And also just to announce, we have two other conferences coming up soon. We have the pre-intern training for vascular residents on June 5th to 7th, and a program about cardiology for the non-cardiologist. That is on June 17th, so please join us for those as well. Okay, it's a great time of year. This is the time of year several years ago when we decided we would ask our graduating core fellows to each give a slightly abbreviated ground rounds format, and they've put a lot of work and effort into preparing these lectures. They always actually have a faculty mentor who's been involved, and it really is one of the highlights of the academic year to have them behind the podium just before they graduate and tell us about their interests and potentially their future plans. So without further ado, I'd like to introduce the first speaker, and then I'll introduce the second speaker before her talk. The first speaker up is Dr. Hassaan Arshad. He's been a fellow of ours for 3 years. He's actually going to stay on at Houston Methodist and do another year of interventional training. Dr. Arshad is a summa cum laude graduate of the University of Health Sciences in Lahore, Pakistan, where he earned 14 gold medals, 5 silver medals, 3 bronze medals. Impressive anywhere, even in the Olympics. He completed his residency at Rutgers in New Jersey, preceded his fellowship here at Methodist. He's very keen on interventional and minimally invasive techniques for both coronary and valvular heart disease. Research focus has been on predominantly multivalve disease and intracoronary imaging and some physiology. And he's also received numerous other awards and a record of publications so far to his credit. So without further ado, Hassaan is going to talk to us about precision PCI and how that's changing the game. Thank you.
Thank you so much. Good morning, all. Thank you for that kind introduction, Dr. Little. So I'm going to talk about precision PCI because that's kind of something that I really hold in high regard. My objectives for this talk are threefold. I will explain the concept and methodology of precision PCI, focusing on imaging and physiology-guided techniques. I'll compare then the outcomes of precision PCI to traditional angiographic-guided PCI. And lastly, I will actually advocate for a broader application of use of intracoronary physiology and imaging. If I can have a show of hands, angiographically, who does think this is a good candidate for PCI? And the broader question is, should we treat it? So similar in this day and age response. And for my talk, it's going to be mostly focused on chronic coronary syndromes. When I do make a shift to ACS, acute coronary lesions, I'm going to highlight that. So without further ado, we'll delve into some background data that most of you guys here already do know. This is the 2000 study landmark COURAGE trial, which showed no significant benefit of PCI versus medical therapy in patients with stable ischemic heart disease. When we talk about BARI-2D trial, BARI-2D trial was similar patients in diabetics, and again showed no significant difference between the two strategies. Fast forward to ischemia trial, and again at 3.2 years, we do not see any benefit of invasive strategy or revascularization as compared to conservative strategy. And when we followed these patients over to 5 years, the results did not significantly change. And then you might think, what am I doing here as an interventional cardiology fellow? While I was gathering the slides, I asked ChatGPT to kind of give me an overview of what my future would look like, and this is what ChatGPT came with. It almost wrote me a letter to Dr. Neil Kleiman saying that I would like to resign from my interventional cardiology fellowship and do something better with my life. However, today I'm here and presenting a compelling argument in the favor of precision PCI. And what do I mean? Precision PCI in selecting the patients with chronic coronary syndromes, precise identifications of which vessels to stent, precise identification of multi-vessel disease and revascularization strategy thereof, precise identification of where to stent, precise knowledge of residual ischemia, precise identification of stent size, expansion, apposition before the patient leaves the cath lab, and precise goal-directed medical therapy to ensure that the patient never ever returns to the cath lab. We'll delve into the data, and the story starts from the first study. And this was a very hard study to do. Even though it was a small study, it was a very hard study to do because it was done in the pre-courage time. And what it showed was it is okay to leave a lesion which looks angiographically significant, however, has an FFR of more than 0.75. At that time, an FFR cutoff of 0.75 was chosen for this study. And as we go into the 15-year outcomes data for the same defer study, we see that the lesions that we left alone based on physiology, FFR greater than 0.75, did not show any increased risk of MI or target vessel death or target vessel MI at 15 years. And this served as a compelling argument of precision PCI in our approach. This concept, which started with the defer study, then continued over to the FAME study. And FAME study was initially the first proof of concept for physiology as guiding our PCI to improve outcomes. This was a multi-center randomized controlled trial which compared FFR-guided PCI with angiography-guided PCI for the management of multi-vessel coronary artery disease. The study was conducted in patients who had multi-vessel coronary artery disease and a stenosis that visually appeared more than 50%. The patient was randomized to angiography PCI versus FFR-guided PCI. And these are the results of the FAME study. The benefits started to reap up at 30 days and continue at 1 year. And now we also have 2-year data for this initial FAME study, and there was a significant benefit of FFR-guided PCI over angiographic-guided PCI only. What are the other results that we got from this FAME study is we will implant less stents. A mean of one stent less was placed in the FFR group. What else do we understood in our FAME study was most of these lesions can be downgraded. A lot of multi-vessel disease were downgraded to single-vessel disease or two-vessel disease in the FAME study. And that actually was very intriguing because this was potentially the start that is the angiographically looking multi-vessel disease truly a multi-vessel disease. And Eric Walbel in his French registry did something very intriguing. So what he did was he did a registry data. This is French registry data where the interventional cardiologist performs an angiogram and gives it its treatment decisions. So the 11% patients go to the cabbage, about 37 go to PCI, and 52% optimal medical therapy. After that, an FFR is done in all these 945 patients. And how did they change the treatment decisions? If you see visually, not by much, but let me tell you how the subgroups changed. So about 17% of the patients moved from the medical therapy group to the PCI or bypass group. About 20% patient moved from the PCI to the medical therapy or bypass group. And very interestingly, about 8% patient moved from bypass, 7% going to medical therapy, and 1% going into PCI. 45% of the patients had their decision in treatment strategy changed based on physiology. And that gives us a compelling idea to actually compare our FFR-guided approach and compare it to medical therapy. This was done in the FAME2 study, where there was all stable CAD patients. They were scheduled for a PCI stent, about 1,200 of those patients. After they were scheduled for a PCI, they actually underwent FFR in all those target lesions. If the FFR was negative, they went to this registry data and they were done medical therapy. However, if the FFR was positive for ischemia, they were then randomized 1-to-1 to medical therapy or PCI with medical therapy. And they were followed up to 5 years. What did the FAME2 results show us? PCI in patients who have FFR positive lesions actually does better in terms of major adverse cardiovascular events to medical therapy, which was kind of conflicting to the earlier studies of Courage and Bari 2D trial. So now what in essence I'm presenting is that FFR is one of the few techniques in interventional cardiology that is actually saving US taxpayer dollars as well as is improving outcomes. Now I'm going to further delve into how physiology can guide us with precise identification of stent placement. So now here, this is an LAD angiogram. We have 3 lesions in tandem or serial lesions, 1, 2, and 3. The IFR at the tip of this wire shows 0.64. The IFR cutoff is 0.89, so it's truly an ischemic LAD territory. However, in this scenario, we are unsure how many stents does the patient need, where the stents should be placed, and can we ever establish normal blood flow to relieve angina. Now I'm going to talk about IFR pullback. So if you look at this IFR pullback, so what essentially the operator is doing, he's pulling back and looking where is the hemodynamic drop-off and where is the hemodynamic drop-off the most. If you see in lesion 1 and 2, there's maximum or most of the hemodynamic drop-off, whereas there is very little drop-off at lesion number 3, which angiographically looked the most significant. So this case highlights the importance of IFR pullback for assessing tandem or serial lesions. It demonstrates the need that we need to rely on physiological measurements rather than visual assessment alone for accurate assessment of lesion significance to guide optimal treatment strategy. While we're on the topic, I'm going to go and switch gears to another concept which we can elucidate through IFR pullback, which is making accurate treatment decisions. So on the right side, we have an IFR pullback with no focal stenosis, looking like a diffuse disease. Whereas there is focal disease with a focal stenosis. Both of these are IFR pullbacks of an LAD. And there's a focal jump, which denotes that there's a focal disease in that LAD territory. These are 2 different disease entities. And one can argue that by focal disease, one can put in a nice stent here and reestablish flow, whereas in the diffuse disease, while you're going to need longer stents, and even with that, you might not be able to restore normal physiology. And one can argue that these patients can be best medically managed or maybe bypassed as a potential target, and we have data for those. Moving on, IFR co-registration is another graphical representation of this IFR pullback, which actually tells us where the huge drop-off is and where can we put in our stents exactly to alleviate ischemia. On the right side, again, there's a diffuse LAD disease where there's a focal RCA proximal lesion. Now, when we're talking about this diffuse disease and the focal disease, we are thinking about the residual ischemia that the patient is going to have after the PCI. In this, even if you stent this, the patient will have a significant residual ischemia where you can alleviate all the ischemia by putting in a focal stent. So that led us to actually investigate how much residual ischemia are we allowing our patients after a successful PCI procedure. And that number is about 20% based on this registry data. 20% of the patients after PCI are leaving the cath lab with still positive FFRs. That led to this DEFINE PCI trial. The DEFINE PCI trial with Greg Stone and Alan Jeremias, they tried to investigate how much and what is the root cause of this residual ischemia. The vessels with a spot baseline IFR of less than 0.89 were identified. A successful angiographic PCI result was obtained, and once the operator, the interventional cardiologist, was confident in his job, a blinded IFR was then done to see how much residual ischemia is there. In this, we can see that about 24% of the patients had an IFR value of less than 0.89, which is positive for ischemia. One might say, oh, these were the patients who had diffuse disease, but the data shows otherwise. Of those 24% with residual ischemia, 81% had focal disease. About a third had a focal disease proximal to the stent, about a third had distal to the stent, and about a third, or more than a third, had in-stent. So this was a geographical miss proximal to the stent, inside the stent, and a geographical miss again distal to the stent. And that makes me ponder, what can we do better to alleviate ischemia in these stented arteries? And the answer in part lies in physiology, but the answer in part also lies in intravascular imaging. So for a recent meta-analysis that we were doing, I searched how much data we have for intracoronary imaging. Just randomized trial publications, we have about 27 randomized trial publications in this space, which show a benefit of intravascular imaging compared to angiographic PCI. The one in black are IVUS, the one in red are IVUS and OCT, and the one in green are OCT only. All these trials had composite endpoints because of low event rates, but I'm going to talk more what is unambiguous, unequivocal endpoint, and that is mortality. This is a major meta-analysis, about 12 of major meta-analyses, which all showed a reduction in cardiovascular mortality in both randomized control trials and non-randomized control trials and registry level data. This leads us to talking about 3 large randomized control trials that were done in intravascular imaging space. IVUS XPL was done in long lesions. IVUS Ultimate was done in all comers, IVUS versus angiographic guided PCI, and about 1,600 patients were enrolled in the latest Renovate Complex PCI clinical trial, where we looked at utility and efficacy of IVUS in complex coronary artery lesions. And all this data, we have IVUS XPL 5-year data, which was a composite primary endpoint of MACE. We see that the curves separate early and continue to separate in the favor of intravascular imaging. Ultimate 3-year trial, we see that the primary endpoint was target vessel failure, and the curve separated early at 1 year, and it continued to separate at 3 years of follow-up. That brings me to the Renovate Complex PCI trial, which was done in the complex CAD cohort, in which left mains were included, bifurcations were included, long lesions were included, and what that data shows for target vessel failure was similar data, all in the favor of intravascular imaging. I also want to take a moment for you to see these pre-specified secondary endpoints, and you can see that we have a benefit of target vessel failure, but we also have a statistically significant benefit of cardiac mortality. And this is an unpublished data from our own research where we did meta-analyses of all this, and we looked at the cardiac mortality, and again, it echoes the same thing. Intravascular imaging guided PCI reduces cardiac mortality. Now, it is intuitive to think, how about if we combine both intravascular imaging and physiology? Do we have evidence that we do better, good, or worse? So I'm going to delve into, lastly, towards the end of my talk about Syntax 2 trial. So Syntax 2 was something similar to Syntax 1, however, with few key differences. In all these patients, there was multi-vessel, three-vessel disease, de novo three-vessel disease, and there was clinical equipoise, and all these patients were, in this arm, was referred to PCI. So as all trial and studies, this also had problems because this was a single-arm study. There was no control. They were comparing the results to the previous Syntax 1 study. But even though the results it shows are very enlightening. So all those who had de novo three-vessel disease, IFR was done in all intended to treat stenosis. And IFR cutoff was chosen to be 0.86 and 0.93. 0.93, the stenosis does not get treated. IFR less than 0.86, it gets treated. If it's in the gray zone, then an FFR is done to further delineate which route we're going to go, and an FFR of less than 0.8, we did fix the stenosis with a Synergy drug-eluting stent. IVUS optimization was somewhat mandatory in this trial, and on top of this, there was a very strict optimal medical therapy with strict LDL control in this group. What did we learn from this trial? 98% of the patients got physiology performed. About 84 to 87% of the patients got IVUS performed or intracoronary imaging performed for stenting these arteries. And this was unlike the Syntax 1 trial. 46% of the truly multi-vessel coronary artery disease were downgraded to either two-vessel disease or single-vessel disease. Less stents were implanted when you compare to Syntax 1 study. And what were the results? The Syntax 2 PCI outcomes, we see a marked decrease in major adverse cardiovascular events at 10.6% compared to 17.4% in Syntax 1 study. Keep in mind, Syntax 1 study was a bare metal stent study. Texas stents were used. However, the difference is just mind-boggling, shocking. And when we overlaid this data from Syntax 2 onto Syntax 1, here in the solid red is the Syntax PCI outcomes. In the dotted red is Syntax bypass outcomes. And in the blue are the Syntax 2 PCI outcomes. Even though it's a single-arm study, when you compared it to the Syntax 1, the outcomes were statistically better than Syntax 1 PCI and even Syntax 1 bypass. Although it is unfair to compare these two because these were done in two different eras, however, it tells you the power and importance of physiology and intracoronary imaging guided PCI. I'm going to leave you with these thoughts. Precision PCI and imaging guided physiology guided PCI techniques significantly surpass traditional angiography guided PCI in efficacy. This transition to precision PCI makes a major milestone in interventional cardiology, signaling a promise in better patient outcomes. And embracing this is not just beneficial or optional, it is essential for elevating the standard of patient care in our field. I thank you all, and I'll take any questions.
All right, well, thank you, Hassaan. I'll comment with, I'll start with a comment that was really masterful. You clearly demonstrated a command of the data and the field, and you started with a clear path of what you were going to discuss. You discussed it, you wrapped it up. So from a presentation perspective, very well done. You made us proud. Open up to some questions from anybody in the audience. I see Dr. Zogby with the microphone.
Very nice presentation, really, and a lot of areas for research and more targeting with physiology or imaging. The question to you, you mentioned a trial where there were sequential lesions or that IFR was done and it was significant and there was no intervention. It was like 20% or so. So if this was done already, meaning the catheter was there, you got the physiology, there must have been a reason not to intervene.
Say that one more time, Dr. Zogby.
See, there were some residual
Correct.
areas of stenosis, I forgot the name of the trial,
Correct.
where the IFR or the physiology was performed,
Correct.
and it was abnormal, and there was a reason, I don't know what the reason was, of not to intervene because already the physiology was assessed.
So in those cases, we can go back. In those cases, if the physiology was performed and it was not intervened,
Yeah, this one.
correct. So this was blinded IFR. So
Oh, blinded.
yeah, so this was blinded IFR. So this was a proof of concept. So the interventional cardiologist was not told about the final IFR readings. So it was done as a proof of concept to kind of see how many of those patients are leaving the cath lab after. So the interventional cardiologist in this study was blinded to the results of the post-IFR.
Hassaan, great presentation. One comment, I think this will agree with precision PCI. That does translate into that, before going into, you have to sit down with the patient and the family because patients expect that their lesions are going to be stented.
Correct.
Education, cultural change.
Correct.
Where do you think IFR or cath lab physiological testing versus non-invasive stress testing, viability testing?
Correct.
Where do you think that is?
So currently, our ESC guidelines and revascularization guidelines say that if the patient does have ischemia, documented ischemia, and the lesion in the cath lab corroborates, then you're okay to stent without investigation of IFR. However, when there are discordant or you have a patient with stable CAD who's coming to the cath lab without a previous non-invasive stress test, you should investigate it with an IFR if the lesion is less than 90%. So again, to your point, Dr. Fida, very important. You have to sit down, talk to the patient's family, talk to the patient, have them on optimal medical therapy. Whatever I have presented does not say that every IFR positive lesion needs to be stented. What I am essentially saying in today's talk is if this patient has unacceptable angina despite medical therapy, IFR and imaging-guided PCI will lead to better patient outcomes.
So that's an excellent presentation. Just follow up on Nadia's comments here. I think the more we know about these different modalities, it makes it, we just know how much we don't know. Like in the heart failure, with the recent studies, which shows that with the people with the low EF, with the ischemia, with the viability, that was a no-brainer, starting this, just a year ago for just that. And
Correct.
there was no difference.
Correct.
In anything, as far as the EF improvement, cardiovascular events, there was no difference.
Correct.
So I think a comment, and also just want to get your thoughts on that group of patients with the low EF, with the ischemia and viability. I mean, it's with that new trial that shows no benefit. Where do you think this practice is going, and what we need to do to understand that specific group of patient better?
Correct. So you're referring to the BCIS trial, which was done in low EF patients with multivessel disease and with documented CMR viability in most cases, however, did not show any improvement in the EF or outcomes in terms of hospitalizations for heart failure. I think that is important. In my mind, it is the data is out. It is kind of conflicting with the previous STITCH study, which did show revascularization benefit. I think in my mind, the answer in part lies to intracoronary physiology, intracoronary imaging to optimize the PCI outcomes, but answer in part also lies that to understand ischemic cardiomyopathy as an entity, that are they truly have ischemic cardiomyopathy or they have bystander multivessel disease, which is kind of non-significant. So it would be interesting to see if in all those multivessel disease in BISIS trial, they did an IFR to make sure that it was actually ischemic lesions that were stented and then see a benefit. I think there is more to come in terms when we employ this notion of precision PCI in our routine PCI cases, which has not been the case, because just from the FAME trial, FAME-3 study, we know that intracoronary imaging is only 12% in United States, or that trial data was like just 12%. So I think once we incorporate this, we understand, are they truly ischemic lesions, and then we stent, and then we see if there is any outcome. I think the jury is out on, still, the jury is out. I think it's not a case closed for ischemic cardiomyopathy, because we have to truly establish was those all lesions ischemic, or it was just bystander moderate disease that we just stented and aiming to get in EF recovery or better patient outcomes.
We're going to, Hassaan, thank you. You're absolutely off the hook. You did a masterful job of giving long, detailed answers to limit the total number of questions. So, very well done. Have a seat. Thank you. Round of applause, if you don't mind. Okay, so this is an absolute pleasure to introduce our next ground round speaker this morning. Nsahlai is graduating from our fellowship program end of this month. Her training includes internal medicine training at Brigham and Women's Hospital in Boston, medical school at Meharry Medical College in Tennessee. Prior to that, she obtained her undergrad and master's in chemical engineering at the University of Rochester, and actually pursued a couple of years of work as a process development engineer in the pharmaceutical and biotech industry. So during her fellowship, Michelle has been very focused on electrophysiology, doing research in atrial fibrillation, as well as pacemaker implantation in heart failure and post-transplant patients. And after her graduation, we're very pleased to note that she'll be going off to do an EP fellowship in Indianapolis, Indiana. So Michelle is going to speak to us this morning about, not that. We can get Michelle's slides up, please. Pacemaker something or other, but why don't you come on and tell us, Michelle? That much I remember. Cool stuff about pacemakers, yeah. All yours, Michelle. Actually, let me get out of here. There we are.
Okay. Good morning, everyone. My name is Michelle. I'll be talking about leadless pacemakers. In 2023, is it time to lose the wires? So I'll do a brief recap on the evolution of cardiac pacemakers. Back in the 1950s, pacemakers were these large devices that were external, and they were connected via an external cord. There was a municipal power failure in Minnesota that led to the tragic death of a baby. And as a result of this, Dr. Lillehei spurred one of the engineers to create a battery-powered pacemaker to eliminate the possibility of such a tragedy. Over the years, you've seen the miniaturization of pacemakers. There's internet-based remote monitoring. You've seen that there are new cardiac MRI-compatible pacemakers. And over the past 50 years, we've also managed to extend battery longevity for a lot of pacemakers. A new shift in paradigm is the emergence of leadless pacemakers. And the reason this is important is that leadless pacemakers allow you to mitigate some of the risk associated with subcutaneous pockets and leads. So a brief recap of a transvenous pacemaker system. This is a dual chamber pacemaker. You do have the subcutaneous pocket that houses the pulse generator, or CAN, which contains the battery as well as the circuitry. You have the leads that are insulated coils that travel to the myocardium and are able to deliver a depolarizing signal as well as sense intrinsic myocardial activity. The leads attach to the myocardium either via an active fixation mechanism or passive fixation. The reason it's important to go over this is so that you can appreciate just the amount of hardware and all the areas where things could go wrong. So some of the clinical complications with transvenous pacemakers include dislodgements, insulator and conductant breaches, connector issues, venous thrombosis, infections, erosions, pocket hematomas, pneumothorax, Twiddler syndrome, which happens when some patients over-manipulate their pacemaker implantation site and cause a dislodgement of their leads, as well as patient aesthetic concerns. This slide here is just to reiterate some of the issues that you occur with traditional or conventional pacemakers, such as the fact that leads sometimes could be thrombogenic, and in patients with PFO, there's an increased risk for stroke, as well as tricuspid regurgitation when the lead travels through the tricuspid valve and could impinge the leaflets or prevent proper coaptation of the tricuspid valve leaflets. So leadless pacemakers, what's out there? You have the Micra by Medtronic, which was approved by the FDA in 2016. You have the Advair VR, which is made by Abbott, approved by the FDA in April 2022. And you have the new kid on the block, the dual chamber Advair DR, which is pending FDA approval. On the bottom left-hand side, you have a receiver electrode for the YCRT system, which is the first wireless LV endocardial pacing system. So let's talk about the Micra. The Micra occupies about 90% or more of the current market, and so a good part of my talk would focus on it. It's 93% smaller than a regular pacemaker. The volume is about 0.8 mils. It's designed to pace only the right ventricle, so therefore VVI or VVIR mode. It's implanted directly into the right ventricle using a catheter as well as a specialized delivery sheet. Vascular access is obtained with a 23 French catheter. It also has an accelerometer for rate-responsive pacing. What's really interesting about the Micra AV is that this accelerometer is able to detect mechanical atrial activity and can deliver AV synchronous pacing. There's an AV synchronous algorithm in the Micra AV that has been validated in multiple studies and have shown that patients are able to achieve up to 85% of AV synchrony. The estimated battery life for the Micra is 8 to 13 years, depending on how it's programmed. Here is a slide that just shows the Micra on imaging, X-ray, cardiac CT, as well as echo. Typically, the Micra is implanted in a mid-septal location in the RV. This is what the Micra transcatheter pacing system looks like. You have an introducer, a dilator, and a specialized delivery sheet that is used to deploy the device directly into the myocardium under fluoroscopic guidance. When deploying the Micra, you do want to target a mid-septal location to avoid the high incidence of cardiac perforations that have been noticed when the device was implanted in a more apical location or against the free wall. So who is the Micra appropriate for? It's appropriate for patients with an increased risk of pocket infections, such as patients with poorly controlled diabetes, immunocompromised patients. It's also good for patients with bilateral subclavian stenosis and occlusion, patients with increased risk of lead-related complications or a history of multiple CIED infections, patients who are old and frail. Sometimes these patients tend to have pocket erosions. Patients with permanent AFib and high grade of AV block. This particular applies to the Micra VR, which is not able to track atrial activity. The caveat is you do want to implant these devices in patients with normal LV function because should the patient require CRT upgrade, we're not capable of doing that with the current leadless pacemakers. The Micra is also appropriate with patients with a low anticipated pacing burden, and patients with normal sinus rates and AV block can have the Micra AV. The reason this is important is because the Micra studies have shown that the Micra AV algorithm tends to not work as well when the sinus rates are over 100, 105, or 110. It is also utilized for patients who are pacemaker dependent and here in the hospital after they've had their devices extracted are on prolonged antibiotic therapy. While awaiting the implantation of a new device, the Micra can be put in to minimize their hospital stay. So I'll delve in here into the original Micra trial that was published in the New England Journal of Medicine in 2016. It was a prospective, non-randomized, single-study group trial to evaluate the safety and efficacy of the Micra. It is important to note that up until date, there have been no randomized trials comparing conventional transvenous systems to leadless pacemakers. The primary safety endpoint was freedom from system-related or procedure-related major complications such as cardiac perforation, issues at the groin site. Enrollment was completed in 2015. The primary efficacy endpoint was the percentage of patients with low and stable pacing capture threshold at 6 months and an increase of less than 1.5 volts from the time of implantation. The reason this is important is that when a device is implanted, you really do want to make a note of your thresholds and you want to monitor these thresholds over time and make sure that they are stable, as well as the impedance and R and P wave amplitudes. They also did a post hoc analysis where they compared the rate of major complications in a cohort of 2,667 patients with transvenous pacemakers from 6 previously published studies. As you can see, you do have low and stable thresholds on the right. You also have consistent R wave amplitude, and you have consistent impedance over time through 12 months. The reason we look at the impedance is because impedance gives us a way to assess the lead integrities to know whether there are fractures or bridges in insulation. The Micra trial showed a 99.2% success rate of implantation. The primary safety endpoint was 96%, and the primary efficacy endpoint of 98.3%. These were compared to performance goals based on historical data of 83% and 80% respectively. It is worth noting that during this implantation, there were no dislodgements. Here, I would go on to talk about, again, the same trial. As you can see, the leadless pacemakers had 51% less major complications, which include cardiac perforation, or as well as dislodgements into the pulmonary artery or other like serious vascular complications. You also had decreased hospitalizations, 2.3 versus 3.9 for transvenous pacemakers, and fewer system revisions, 0.4 versus 3.5. To reiterate, the Micra CED study, which basically was the coverage for evidence development study, was done to continue to assess the safety and performance of leadless pacemakers, and it essentially showed what the initial trial showed, which is fewer complications compared to transvenous pacemaker, and no difference in all-cause mortality at 2 years. Another sub-analysis or subgroup study was done in patients with comorbidities, such as patients with malignancy, end-stage renal disease, COPD, and diabetes, as well as tricuspid valve disease. And again, the leadless pacemaker group had fewer chronic complications and reinterventions at 2 years after implant. There were no differences in acute complications. This just goes to show that the benefits of leadless pacing persist among high-risk patients. It's also worth noting that a lot of the patients who end up getting, the mean age for the patients in this study was about 75, 77 years of age, and showed that leadless pacemakers tend to be implanted in the sicker group overall. The MICRA-CD study, this is a 3-year follow-up, again, similar to what we saw in the first and second MICRA trials, 32% lower rate of chronic complications, 41% lower rate of device reinterventions, a decreased rate of infections, and a decreased rate of heart failure hospitalizations. The difference in heart failure hospitalizations was about 10%. The reason this is important is that compared to the previous trials, this was the first time they were also looking at heart failure hospitalization, and this study was hypothesis generating. They were trying to see whether this heart failure hospitalization could be used as a proxy to look at leadless pacemakers and the incidence of pacing-induced cardiomyopathy. I've highlighted in red one of the main issues that tends to come up with leadless pacemakers is their higher incidence of cardiac perforation, tamponade, and pericarditis compared to transvenous pacemakers. So let's talk about retrievability. Can the MICRA be retrieved? Yes, it can. The MICRA transcatheter pacing system can be retrieved via the femoral vein with a MICRA introducer, a MICRA delivery catheter on an Agilis steerable sheet, and a snare. A lot of the studies out there show the MICRA being retrieved under fluoroscopy, but here our very own Dr. Sherman does it with ice and has been successful in removing a device that was implanted that was in the patient for up to 12 months. Some of the reasons for retrieval include elevated capture thresholds after the device is deployed, endovascular infection, and a need for a transvenous device such as an upgrade. There is a paper that shows the worldwide experience on the MICRA retrievals, and this paper, they talked about 40 successful MICRA retrievals worldwide. Of these 40, 29 of them, the day we had the data for them, immediate retrieval was retrieval that was done in the implant procedure, and that happened in 11 patients. And delayed retrieval was in 18 patients with a median duration of 46 days. The mean procedure duration was approximately 2 hours. No serious complications occurred. It's worth noting that at this time, there's still very limited experience on device removal after it has been fully encapsulated. Now, this slide goes to show how when the device is fully encapsulated, the retrieval feature at the end of the device is buried in the myocardium, and there is a chance that the patient might require sternotomy in order to remove it. I would briefly go over the Leadless 2 phase 2 trial, and this trial was done to assess the performance and efficacy of the Advair VR, which is the leadless pacemaker created by Abbott and approved in 2022. As I showed before, there's a high rate of implantation success. 93.2% of patients were free of serious adverse events at 12 months, and 95% had acceptable pacing thresholds, impedance, and RV wave amplitudes at 12 months. What's worth noting again is that with leadless pacemakers, like I mentioned before, cardiac perforation, tamponade, and pericardial effusion appears to be one of the most serious and feared complications. The estimated battery life for a leadless 2 Advair VR device is 16 to 18 years. So let's talk about infection in leadless pacemakers. Why is the rate of infection so low in leadless pacemakers? As of now, only a handful of case studies have shown micro device infection, a rate of 0.002% compared to 1.0 to 1.3% for transvenous pacemakers. And these numbers can be higher in patients who have retained devices or have had multiple leads placed. Possible explanations include the small surface area of the device for the MICRA or any leadless system compared to a pacing lead, the absence of a subcutaneous pocket and lead, the absence of operator handling during device deployment, and it is proposed that device encapsulation or endothelialization might decrease the bacterial access to the device. Furthermore, the material coating the micro device is perylene-coated titanium, which in some studies have shown to have antibacterial properties compared to titanium. Again, another possible explanation was the turbulence and high velocity pressure in the right ventricle versus the thoracic veins might be a reason why the rate of infection in these devices is pretty low. It's interesting to note that in the original micro study, 16 patients became bacteremic and developed endocarditis. However, the device did not have to be extracted in any of these patients. So the pros and the cons of leadless pacing compared to transvenous pacing: you have no pockets, no leads. It's useful in cases where venous access needs to be preserved, such as patients with end-stage renal disease, good for patient comfort and aesthetics, and like I showed earlier, you have a lower incidence of midterm and long-term complications. Some of the cons include the fact that there is no lead in the atrium, so there's no atrial pacing. AV synchrony is imperfect, although the micro AV has been validated and has shown to provide up to 85% AV synchrony, there's still a lot of work still needs to be done, and a lot of optimization needs to be done to the algorithm. You also have no conduction system pacing, no wireless remote monitoring, higher cost, and there is still a lot of work that has to be done with regards to retrievability. So I'll switch gears here and talk about the new kid on the block, the dual chamber leadless Advair pacemaker. And what it is basically two discrete devices that communicate through the patient's blood pool and the myocardium. The device utilizes a mode of communication known as conductive communication for both the programmer and device-to-device, also known as implant-to-implant communication. What it is the device in the ventricle is the parent, the device in the atrium is the child, and the parent basically confirms programming and talks to the child, and they communicate throughout the cardiac cycle in a beat-to-beat manner to ensure AV synchronous pacing. These devices are delivered into the ventricle and atrium using a delivery catheter. Both are designed for chronic retrievability. And it's worth noting that the single chamber Advair can be upgraded to the Advair DR. This device has not yet been approved for commercial use. This is what the device looks like on imaging, on X-ray. And this is schematic just basically shows how in this eye-to-eye communication, the device in the left ventricle, the parent talks to the child by transmitting this implant-to-implant signals, which are basically a low energy mode of communication that throughout the cardiac cycle. Should the eye-to-eye communication be interrupted, each device would revert to its functional pacing mode in order to maintain support of the ventricle. The Advair DR I2I study was done to evaluate the safety and efficacy of this dual-chamber leadless pacing system. It was a prospective multi-center, again, single-group study trial. 63.3% of the patients had AV block, 33.3% had sinus node dysfunction. Primary safety endpoint was freedom from device or procedure-related serious adverse events in 90 days. And the primary performance endpoints were adequate atrial capture threshold and sensing amplitude at 3 months, as well as at least 70% AV synchrony at 3 months while the patient was sitting. AV synchrony was defined as a paced ventricular event within 300 milliseconds of an atrial event. The study showed that this device could be implanted with a 98.3% implant success rate. 90.3% of patients were free of serious complications at 3 months. 90.2% of patients adequate atrial capture and sensing at 3 months, and 97.3% of patients achieved greater than 70% AV synchrony. These were compared to performance goals for all three primary endpoints, which were 78, 82.5, and 83, respectively. So leadless pacemakers, what do we know? We know that the success rate for implantations is greater than 98%. We know that it can be implanted in a select group of patients at this time. About 20% of patients who meet indications for pacemaker implantation get a leadless pacemaker. The electrical performance is 98.9% and 91.5% at 1 and 2 years respectively. We also know that leadless pacemakers have lower rate of acute complications compared to transvenous pacemakers, and chronic complications are lower compared to transvenous pacemakers. They still have a higher rate of pericardial effusion and cardiac tamponade compared to transvenous pacemakers, 0.8% versus 0.4%. And we've also seen that they're more frequently implanted in sicker patients compared to conventional transvenous pacemakers. What we don't know, we do not know at this time the long-term electrical performance of leadless pacemakers. We do not know the incidence of pacing-induced cardiomyopathy, although there have been a few studies that have been done. We don't fully know the impact on tricuspid valve regurgitation. There have been some case reports where they noticed a worsening in TR after implantation of a leadless pacemaker. We do not know how many can be implanted in the right ventricle at this time. There have been studies involving cadavers that show that up to 3 leadless pacemakers can be implanted. We don't know the true incidence of device dislodgements, and we do not know how it compares to conduction system pacing and true battery longevity. So I will finally talk about the YCRT system, which is an LV wireless endocardial pacing system. It is comprised of an existing conventional pacemaker that works with a subcutaneous transmitter/pulse generator implanted, as well as a small receiver electrode that is implanted in your left ventricle. The transmitter receives energy senses the RV pacing output, and it transmits ultrasound energy to the receiver electrode in the LV, such that this energy is converted into an electrical signal in order to pace the LV and deliver RV and LV synchronous pacing with a delay of about 2 to 5 milliseconds. The SELECT LV study was done to evaluate the safety and efficacy of this device, and it showed, I'll take a moment. This device is actually designed for patients who are non-responders to CRT or are not able to get CRT because they have difficulties with cannulation of their CS. So the SELECT LV study was done to assess the performance and efficacy of this device. 97.1% of patients had bi-V pacing at 1 month. This study only had 35 patients, and so it's just worth mentioning to know that the study sample size was really small. 85% of patients showed an improvement in the clinical composite score, which basically looked at the patient's NYHA class, the number of heart failure hospitalizations, and the patient's global assessment about how they were doing. 66% showed an absolute increase in left ventricular ejection fraction of greater than 5% by TTE, and the device and procedure-related complications occurred in 8.6% of patients within 24 hours and 8% from 24 hours to 1 month. This just goes to show that the SELECT LV study showed that the YCRT performs similarly to other conventional CRT, as shown by the data from other studies such as Prospect, Miracle Reverse, and Miracle ICD. You saw comparable clinical and structural outcomes to conventional CRT, and changes in reverse remodeling in the LV was noted with this system. The SOLVE CRT trial, which is the final trial I'm going to talk about, was a prospective randomized trial to evaluate the safety and efficacy of the YCRT in CRT non-responders and previously untreated CRT-eligible patients, as well as CRT-eligible patients deemed too high risk for conventional CRT upgrades. Patients were followed at 1, 3, and 6 months. At each follow-up, they did the device interrogation, blood work, and physical exam was done. A 12-lead EKG and transthoracic echo was performed at 6 months, and the primary safety endpoint was, again, freedom from device or procedure-related adverse events through 6 months. And primary efficacy endpoint was a mean change in LVN systolic volume, which was defined as a change of greater than or equal to 15% from baseline through 6 months. The results of this study showed 16.4% improvement in heart function at 6 months, as well as 80.9% freedom from device and procedure-related complications. The device met its primary efficacy and safety endpoints, and it even exceeded the targets. Based on the Kansas City Cardiomyopathy Questionnaire, Most of the patients who were in this trial demonstrated, 46.7% of the patients in this trial demonstrated improvement in all aspects of these questionnaire. It's also worth mentioning that they looked at the QRS of the patients at baseline and compared it to after the device had been implanted, and they noticed a decrease in the QRS duration of 20 milliseconds. So what lies ahead? We do have the modular CRM system by Boston Scientific, which combines a subcutaneous ICD to a leadless pacemaker. We are also thinking of perhaps a future with biventricular leadless pacemakers, as well as conduction system pacing with leadless pacemakers. Under research is also light-powered battery-free pacemakers. So like I mentioned earlier, is it time to lose the wires? I don't think so, not yet. Leadless pacemakers are safe, they perform well, you have to choose the right patient, you have to know your patient. However, a lot of research needs to be done to expand the indication for leadless pacing. But let's just say for now, the possibilities are endless and the future is very exciting. Thank you.
Thank you, Michelle. An excellent overview as expected. We have time for just a couple of questions, so I'll start off with one. I do see Paul. Just give me a second here. Ask one question. I had two. One was I was going to ask you about the potential for the synchronous AV, but you covered that very nicely. That's clearly coming and looks like it's about to be approved. The one I had was really about end of battery life. Let's say you are 8 years from now. Technically, what do? Do you put in a second one and turn off the first one? I know they're now endothelialized and hard to remove. What's the expectation for, the second one? How does that work?
So typically, the manufacturer for the Micra recommends that these devices be left in place at end of life, and the device itself is turned off, is programmed such that it turns off. However, it is safe to assume that you could put in a second device. If you think about, like I mentioned earlier, this device is only about 0.8 mils. So, sorry, 0.8 mils. So it does occupy a very small of the RV volume. However, you can also choose to remove this device should the patient need a CRT upgrade. So there's still work that needs to be done in deciding what our strategy will be moving forward. Should we implant a second one or, retrieve the initial one and implant another one? Yeah.
Okay, thank you. So the strategy of rack them and stack them. All right, Paul, you had a question.
Right. So great presentation, Michelle. I really enjoy it. I think your engineer background was noted here, and we really, I feel I actually learned a lot from you. So I think it's important to show the key points of your presentation. So with all the learning that you did, which is the patient selection you think you'll benefit at the moment for leadless?
So at the moment, the patient who would benefit the most would be a patient who's at a high risk of infection. Preferably, you want a patient who has a normal LV function because, like I mentioned, we don't have the capability of upgrading these devices right now. You would also need a patient who's less likely to have a high pacing burden when the pacing burden is low, about 20%. You would not want to put this in a patient who has a really, really high pacing burden because there is the possibility of RV-induced cardiomyopathy, even though there was one study that showed that this was 3% compared to 13% in patients with transvenous pacemakers. You could consider this also in a patient with atrial fibrillation, where you no longer want to track the atrium and you just want to pace the ventricle. The Micra AV could work for, again, patients who are, normal LV function, elderly, not very active, because like I mentioned earlier, the AV synchrony algorithm tends to break down at higher heart rates. And the reason for this is because you have fusion of the E and A waves or certain signals that make it harder to distinguish them, tell them apart. So you would not really, it might not necessarily work well for a patient that's very young and very active and that might get very symptomatic from loss of AV synchrony.
Michelle, beautiful presentation. I certainly learned a lot, and I thought that was very timely for the audience, for most of us really who are not in the field. And it is very exciting, to see the future and the possibilities. So it sounds to me that maybe an ideal patient also would be along the lines of a nice summary that you gave, is an intermittent high degree AV block in somebody in
Correct.
sinus. So along these lines, I'm impressed by the projected longevity of the battery in these situations. Is that because of patient selection, meaning that we're using patients who need intermittent pacing as opposed to much more continuous pacing? That's one. Another question I have for you, which was intriguing to me, since the preferred site of implantation, Paul and you, is the septum, why is the incidence of pericarditis? I mean, it's kind of unusual for me.
So that when I mentioned pericarditis, I mean, prior to this, with the more and more experience, they're beginning to implant these devices in the septal locations. But the initial studies, these devices were implanted in the apex as well as the free wall, and so it took some time for them to realize that that should be the target location because it would minimize complications. The reason for longevity, again, like I mentioned, or like you mentioned, is the fact that a lot of the electrophysiologists who implant these devices are aware of the pacing burden of their patients, so they choose the right patient who doesn't require a lot of pacing. And then with regards to the Micra, the pulse width duration is set at 0.24 milliseconds, which could potentially also be one of the reasons for increase in battery longevity.
All right, given the hour, we're going to wrap up today. Another round of applause for Michelle, please. That was an excellent grand rounds. Thank you both very much. You've both met the final criteria to graduate, so that means tomorrow night at the ceremony you will graduate.
Pacing threshold.
The pacing threshold, yeah. Thanks very much, all.
Thank you.